Are you ready to elevate your expertise in pediatric critical care? Welcome to the Pediatric Critical Care Fellowship, a premier one-year online program designed to equip you with advanced knowledge and skills in managing critically ill children. Our aim is to provide you with high-quality educational materials and up-to-date pediatric critical care information delivered by a panel of highly qualified international expertise. Our professional panel ensures that the curriculum is current. This comprehensive fellowship is structured as 3 modules, 16 weeks each, with a total of 96 credit hours of in-depth training, delivered by a world-class faculty of international experts. Our curriculum ensures that you stay at the cutting edge of pediatric critical care. Your journey with us includes weekly lectures, MCQs, interactive case-based discussions, journal clubs, and virtual simulations, featuring the latest evidence-based pediatric critical care knowledge, plus a dedicated mentorship program to guide your learning every step of the way. From mastering mechanical ventilation and sepsis management to specialized training in mechanical circulatory support and neurological critical care, you will develop essential skills to manage critically ill children in any healthcare setting. Upon completion of the fellowship, you will enhance your credentials, advance your career, and improve your patient's outcome. With access to a cutting-edge smart learning platform, virtual case scenarios, and real-world applications, this fellowship bridges the gap between knowledge and clinical practice. Join a growing community of critical care professionals who have transformed their careers with this fellowship. Don't miss this opportunity.
Hello, everyone, and welcome to our Pediatric Critical Care Fellowship webinar. We are very glad today that we are restarting our new fellowship and our new batch of the Pediatric Critical Care Fellowship. Today, we have a very special webinar and are focusing on new strategies to improve our PICU care beyond the mechanical ventilator. So anything can improve our respiratory care in our sick children, apart from the mechanical ventilator. This will be our focus today. We have great speakers and moderators today. We have Dr. Mustafa El-Bahiri from UK, Professor Mervat Kamaluddin from Egypt, Dr. Ali from United States, and our great moderators, Professor Michael Canary from Yale University, USA, and Professor Anna Gans from Canada. So very special webinar today. After this intro, Professor Mervat Kamaluddin is going to talk about the cardiopulmonary crosstalks and interactions. Then Dr. Mustafa El-Bahiri will give a very nice case-based discussion, how to improve our patient's outcome. And Dr. Ali is going to talk about lung protective strategies in PICU. Then Professor Michael Canary with Professor Anna Gans will moderate the session by the end. So if you have any questions, please put it in the QA box. So again, Professor Mervat Kamaluddin Mansour, she is a professor of pediatric critical care at Ain Shams University. She's going to focus on cardiopulmonary interaction. And Dr. Mustafa El-Bahiri, he is a pediatric cardiac intensive care registrar at Freeman Hospital. He's going to talk about lung protective strategies, focusing on case-based discussion. Dr. Ali is a pediatric critical care fellow at UT Southwestern and Dallas, Texas, and he is going to talk about improving our patients' outcome through different new innovative strategies. and Professor Michael Canary, along with Professor Anna Gans, are going to moderate the session. If you have any question, inquiries, please feel free to put it in the Q&A box. All attendees should receive their certificate of attendance by next week. If you want not only to hear the lecture, but also to be able to see the transcription with your own language, you can do that by activating or enabling the show caption option in the lower right corner of your screen. Again, we are not here to teach you the basics or the facts. We are here to train your mind to think, to challenge you, to be a better physician. We need to think because we either think or think. With that, I'm going to let you to enjoy Professor Mervat Gamaluddin Mansour talk, and she will talk for about 15 minutes.
Hi, good evening, everyone. We are going to discuss how positive pressure and preload, how it is going to affect the RV afterload, specifically meaning the pulmonary vascular resistance, and how it helps reduction in the LV afterload. Then we'll apply these physiologic concepts on real scenarios in our daily practice in the PICU with the best evidence-based management. Let's start discussing the effect of positive pressure ventilation on venous return. It's actually related to the intrathoracic pressure created during positive pressure ventilation. During spontaneous breathing, there is a creation of negative intrathoracic pressure by the active contraction of the diaphragm during inspiration, which turns the intrathoracic pressure ultimately negative during inspiration. But while during positive pressure ventilation, the intrathoracic pressure is always positive along the whole respiratory cycle. And another key concept in the physiology of the blood flow from the systemic veins to the right atrium is that the driving pressure. And the driving pressure is the difference between the systemic venous pressure and the right atrial pressure. So, spontaneous inspiration generates negative intrathoracic pressure, which is transmitted to the right atrial pressure and creating a more forward flow from the periphery to the right atrium, increasing the venous return and the cardiac output, while positive pressure ventilation reverses this. Positive pressure ventilation, on the other hand, increases the right atrial pressure and narrowing the gradient between the systemic veins and the right atrial pressure and reducing the venous return and ultimately the right ventricular preload. Which might affect the overall cardiac output. And so we should take care of this concept during initiation of positive pressure ventilation or during increment of the positive end expiratory pressure during recruitment. Because patients who are volume dependent and preload dependent can suffer manifestations of low cardiac output based on this concept. How about the effect of positive pressure ventilation on the right ventricular afterload? Pulmonary vascular resistance is the main determinant of right ventricular afterload. And we have two groups of vessels in the lung. These are the alveolar and the extra-alveolar vessels. The pulmonary vascular resistance is the summation of resistance created by both groups of vessels. If we are ventilating our patient on a small volume or a small tidal volumes, keeping the patients much below the functional residual capacity, like patients with atelectasis and collapses. In this situation, we will find the extravascular vessels are tortuous and compressed by these small volumes of the lung, leading to a marked increase of the pulmonary vascular resistance. On the other hand, if we are ventilating our patients by high volumes, and much beyond the functional residual capacity, we are going to compress the alveolar vessels, and again the the pulmonary vascular resistance will be increased. In both situations, whether we are ventilating patients much below or much beyond the functional residual capacity, the RV will suffer by increasing its afterload and the pulmonary vascular resistance. And so in patients with vulnerable RV, we should consider this concept, either not to ventilate our lung in small tidal volumes or small beeps or small pressures, or in the opposite. We need to attain ventilation around the functional residual capacity. And on the other hand, if the RV is suffering, or we have situations with we need to manipulate the pulmonary vascular resistance, we need to manipulate our ventilatory strategy, aiming ventilation around the functional residual capacity. On the other hand, how positive pressure ventilation can unload or help the left ventricle. The left ventricle should create a pressure great enough to push the blood during systole against the high systemic vascular resistance in the aorta and the systemic arteries. And to create this pressure, he should combat against the negative outward movement exerted on the left ventricle by the presence of a negative intrathoracic pressure during spontaneous breathing. So the left ventricle should generate a high transmural pressure to push the stroke volume against this high systemic vascular resistance and combating again the negative intrathoracic pressure. But during positive pressure ventilation, the positive pressure ventilation created inside the pleura by the ventilation, it helps the left ventricle and help movement of the left ventricle inwards during systole to push the blood against the systemic vascular resistance. And so it helps the left ventricle to create less transmural pressure during systole, which is finally unloads the left ventricle and help to reduce the left ventricle afterload. That's why and how positive pressure ventilation will improve patients with cardiogenic pulmonary edema or improve the cardiac output in patients with borderline LV dysfunction. But the main concern is during extubation. Keep watching extubating patients with poor LV dysfunction, because you are going to abruptly increase the LV afterload together with increase in the venous return. So we have a one ventilator with two ventricles and sometimes an opposite effects. Positive pressure ventilation can decrease the venous return and preload, which ultimately can decrease the stroke volume and the cardiac output. It can lead to increase the pulmonary vascular resistance if you are ventilating our patients below or behind the functional residual capacity. And on the other side, it can help the left ventricle, but keep watching during extubation. So we need to ask ourselves which ventricle in our patient is the main risk and main problem before increasing or ventilating the patient or increasing the pressures, and keep watching extubation of your patient. Now we are going to apply our physiologic concepts on real-life cases. The first patient presented with fever, mottled skin with capillary fill time of 4 seconds. He received 40 ml per kg crystalloids. Norepinephrine was initiated for hypotension, but oxygenation worsens with bilateral infiltrates on X-ray. She's intubated and PEEP is escalated for a BF ratio of 1:5, and urine output remains low. As we see, we have a patient with fluid refractory septic shock who developed a moderate ARDS and need escalation of the PEEP while remaining is intravascularly depleted based on a low CVB, high lactate, as well as a low or small urine output. After the PEEP increment, the blood pressure falls further and lactate rises. What happened and what to do next? Why raising the PEEP worsen shock in this patient? It is the same concept, raising the PEEP, increasing the mean airway pressure, leading to increase the right atrial pressure, and so decreasing the preload and the filling of the right ventricle, and ultimately decreasing the cardiac output in a patient who is already depleted. For this condition, do we avoid PEEP increment in ARDS with shock? The answer is totally no. Adequate PEEP recruits the collapsed lung and still indicated for oxygenation. But we need to optimize the preload first. We need to optimize the preload first by reassessment of load responsiveness before PEEP increment, whatever the method you are going to use. And we should correct the volume depletion in patients who are already volume depleted in parallel with lung recruitment, and we target adequate organ perfusion. And we should titrate the PEEP in a deliberate way. We ultimately need to use the lowest PEEP achieving adequate oxygenation, and we should consider decreasing the PEEP trial with compliance with hemodynamic monitoring, and avoid abrupt increment of the PEEP, especially in patients who are hemodynamically fragile, like our patient who had hypotension, poor capillary fill time. And at the same time, we should support the circulation of a patient with septic shock by using norepinephrine and maybe vasopressin in low dose, and as well as considering hydrocortisone in resistant shock. Our next patient having a viral myocarditis with ejection fraction of 18 was intubated due to cardiogenic edema, cardiogenic shock. She was improved on milrinone and diuresis, just the X-ray cleared, and the team is considering extubation. And this is the real challenge in this patient. How we are going to structure extubation in a patient with poor LV function. We need to optimize the pre-extubation phase by confirming a negative fluid balance clinically or by imaging before attempting extubation. We need to maintain the afterload reducing therapy like milrinone, ACE inhibitors, etc. We need to act on any confounding factors that might impair the extubation, like arrhythmias or or fever or electrolyte disturbance. We should structure the weaning by starting a spontaneous breathing trial for the patient, but not only observing the oxygenation parameters. We should observe the hemodynamic endpoints, whether the patient will develop tachycardia or hypertension or rising lactate during spontaneous breathing trial. This means the patient is still having a risk for extubation. And we should avoid abrupt extubation while the patient is still on high pressure settings. And high pressure settings means a high support of the left ventricle function. And after extubation, we should bridge the patient to a non-invasive post-pressure ventilation to preserve some afterload reduction, and observe the patient very carefully, and should have high alert for re-intubation of the patient with development of any manifestations of low cardiac output, whether it is mottling, hypotension, tachycardia, sweating, increasing lactate. So high alert for re-intubation, and don't waste the patient time on continuing the patient on post-pressure non-invasive ventilation. Our last patient is a patient with extracardiac Fontan and day 1 post-operative. He remains intubated for hemodynamic instability overnight. You know, pulmonary flow in the Fontan physiology is entirely passive, driven by the transpulmonary gradient, the Fontan pressure minus the atrial pressure. There is no right ventricle to push the blood from the systemic circulation to the lung. And so the mean airway pressure is actually the real enemy for a Fontan patient. And so the surgical team is pushing for the earliest possible extubation. And by the way, they are right in this recommendation. So how we are going to ventilate patients with Fontan surgery? Our aim during mechanical ventilation of Fontan patient is to use the lowest PEEP and inspiratory times that maintain recruitment and avoid high PEEP strategies whatsoever. We can accept mild hypercarbia to favor pulmonary vasodilatation and lower the pulmonary vascular resistance. We should avoid auto PEEP and watch for breath stalking if the patient is agitated, and we should sedate the patient during ventilation. And the priority is actually for fast-track extubation as a primary goal for Fontan perioperative protocol. Sometimes we can use a non-invasive support to bridge rather than to prolong the positive pressure ventilation. And we can support the Fontan circuit by maintaining adequate preload, maintain sinus rhythm, and even consider pulmonary vasodilators if the pulmonary vascular resistance is elevated by any other causes. So my takeaway is always identify which ventricle or which physiology your patient depends on before predicting the effect of a ventilator change. RV and LV respond oppositely to positive pressures. PEEP has a U-shaped relationship with RV afterload. Both atelectasis and overdistension raise the pulmonary vascular resistance, always target the functional residual capacity. In LV failure, positive pressure is therapeutic. It reduces afterload. But the danger point is extubation when afterload returns abruptly. In single ventricle Fontan physiology, minimize mean airway pressure and prioritize early return to spontaneous negative pressure breathing. In preload-dependent patients like shock or hypovolemic patient or patient with restrictive RV physiology, optimize intravascular volume in parallel with any PEEP escalation and never in isolation. Thank you.
Thank you so much, Professor Mervat Gamaluddin, for this very nice illustration. I like the case-based discussion because we always think, and focus on the clinical aspects, not on the theoretical or hypothetical background. So now we will have a couple minutes to listen to a description of our fellowship, the PICU fellowship, before listening to our next speaker, Dr. Mustafa Al-Bahiri. Welcome to the Pediatric Critical Care Fellowship, which is a one-year online program providing certified comprehensive knowledge and skills in pediatric critical care. This fellowship is a unique flagship program offered entirely online and is structured into 3 modules, 16 weeks each, including lectures, journal club, MCQs, clinical case scenarios. And we have a worldwide fellowship board members from Pakistan, United States of America, Canada, South Africa, Saudi Arabia, Egypt, and more countries. So our diversity not only with the board member, but also with the student is very unique. And because we know that the learning pyramid, when it comes to lectures and reading, is very limited, we are trying to involve our fellows in practicing doing and in discussion through a smart platform. So each module of these 3 modules is 16 weeks of bidirectional education. It's not based on monologue, but rather a dialogue. And we have a weekly questions and answers with evaluation and assessment, critical thinking and appraisal, and we are gathering a panel of expertise. Again, we will have live webinars, workshops, video conferencing, but also using a smart platform. We are engaging our fellows and letting them to have bidirectional education tools through this smart platform. The scientific materials are released each week at 8 a.m. in the morning GMT time, and fellows will have the freedom to navigate the scientific materials and complete their tasks and assignments throughout the whole week. And all activities of our fellows and all of their assignments will be monitored in the platform with a weekly quantitative and qualitative evaluation and assessment. Here is our main topic that will be taught during our first module. We'll start by talking about unstable patient, resuscitation, sepsis, then we'll move to nutrition in critically ill patients, point of care ultrasounds, then we'll focus on infectious diseases. The second module will be dedicated for a specialized topic. We'll focus on a respiratory critical care settings for 1 month, then cardiovascular critical care in another month, and the renal critical care in the third month. The third module will be focusing on advanced critical care management, starting with neurocritical care and traumatic brain injury, moving to endocrine and metabolic disorders, then oncologic gastrointestinal disorders. Upon completion of this fellowship, you are expected to be an expert in the pediatric critical care field and graduate to a trainer and mentor level from a mentee and trainee level and receive American accredited graduation certificate with 96 credit hours. Again, the knowledge has no value unless we put it in practice, and this is our aim, is to involve you and to transform this knowledge to improve our patient care. Thank you so much, and we'll see you in the fellowship. Okay, so our next batch of the fellowship is going to start in October. If you haven't joined, if you are interested, please go ahead and do. We are going to share the link of our fellowship application and registration shortly. And now we have a 15-minute presentation. Dr. Mustafa Al-Bahiri, who is a registrar in the pediatric ICU in Freeman Hospital. He is going to give a case-based discussion with the lung protective strategies in pediatric ARDS patients.
Good evening, everyone. Today I'm going to talk about pediatric ARDS through a case-based discussion with more focus on lung protective strategies and PEEP optimization. Let's start with our case today. So our case today is a 9-year-old girl with a background of truncus arteriosus that was repaired in infancy. She came this time for RV2BA conduit replacement. Surgery was uneventful. She was admitted to PICU, intubated and ventilated on low pressures and low oxygen requirement with good gas exchange. Her post-op echo showed good function, no residual lesion. However, on the first day post-op, trachea secretion showed some signs of possible lower respiratory tract infection, so she was commenced on empirical antibiotic and culture were sent. She was extubated the next day to high flow nasal cannula, 2 liter per kg, but within hours, she had increased vocal breathing, lower oxygen saturation, so the support was escalated to non-invasive by BAP 18/8. On the following day, her vocal breathing worsened. She needed higher pressures on non-invasive up to 22/12 with high oxygen requirement, FI2 0.65. We did X-ray. As you see, there is no right side opacity. We did lung ultrasound, showed coalescent P-line, thickened pleura, subpleural consolidation, suggestive of evolving PRDS. The blood gas was done and showed low SF ratio and low PF ratio. Given this picture of severe PARDS, it was unsafe to continue on non-invasive, so the decision was to intubate and ventilate. After intubation, she had ventilator asynchrony, increased respiratory effort, so the decision to increase sedation and start neuromuscular blocker. The initial setting was pressure control ventilation, PIP 22, PEEP of 10, and was achieving low tidal volume, 2 to 3 ml per kg, which was low and indicating need for higher PEEP. So instead of using empirical high PEEP that could affect the hemodynamics given the background of recent cardiac surgery, we increase the PEEP gradually using serial ultrasound scan to assess the aeration at each step. The maximum we reached was like PIP of 30 and PEEP of 16. With the help of ultrasound, we ended up of PIP 25, PEEP 10, driving pressure 15, tidal volume improved to 6 ml per kg. We kept the rate lower at 15, FI2 improved to be around 0.55. Later, ultrasound showed good recruitment of anterior and upper areas, but the dorsal area remained consolidated with poor aeration. So decided for prone position to improve the homogeneous distribution of transpulmonary pressure and to recruit more alveoli. The regime was around like 16 hours prone and 8 hours supine for 48 hours. The repeated ultrasound showed better aeration and the lung mechanics showed better compliance, and the patient improved and extubated within 5 days to non-invasive. So let's see the Palick definition of PRDS and if it meets our patient. So it is not perinatal lung disease. It happened within 7 days. There is no cardiac failure or fluid opacity, low SF ratio, PF ratio, and high oxygenation index showing severe PRDS, and cyanotic congenital heart and chronic lung disease not applicable to this case. So it is PRDS and it meets Palick 2 guidelines. So let's move to the management. This is a schematic summary of the Palick 2 guidelines. You can see PEEP at or above the PEEP FI2 table is the most agreed evidence for PARDS management, which we followed in this case. We also used neuromuscular blocker, prone position, but were these justified? We will see later in our discussion. And finally, we followed the lung protective ventilation targets and limits as per guidelines. So talking about lung protection, we protect the lung from ventilator, which may cause ventilator-induced lung injury, VELI, or from the patient, which may cause patient self-inflicted lung injury, PCLI. So let's start with VELI. So VELI is an acute lung injury that either inflicted or aggravated by mechanical ventilation and may cause significant morbidity and mortality. The mechanisms of VELI are volutrauma, meaning excess volume, can be limited by controlling tidal volume. Barotrauma, excess pressure, can be limited by controlling plateau pressure. Biotrauma, caused by inflammatory mediator, which can be caused by VELI, so we need to control VELI, and we may use steroid in selected cases as per Palick 2 guidelines. Atelectic trauma, which may be caused by atelectasis and can be reduced by optimizing the PEEP plus or minus prone position if there is no contraindication. Last but not least is ergotrauma, which is a new concept that appeared in the literature in the last few years and mean excess mechanical power. So we need to avoid high mechanical power. But what is mechanical power? So mechanical power, it is the total energy transferred from the ventilator to the patient respiratory system over time, and it represents the stress on the lung during ventilation. There is a lot of formulas used to measure the mechanical power, but I use this simplified formula. The first is for pressure control ventilation, and the second is for volume control ventilation. But you may ask, what does the mechanical power change if it still depends on tidal volume, driving pressure, and plateau pressure? The answer is, if you notice here, the effect of respiratory rate. So imagine with me, two patients have the same pressure, same volume, but one has the rate of 10 and one has the rate of 20. The one who has the rate of 20 has the double energy and the double mechanical power and will be far more prone to VELI than the one with rate of 10. So we need to keep the rate lower and may accept higher CO2 and permissive hypercapnia. So mechanical power is more holistic approach to ventilator-induced lung injury. Also, in pediatric population, you have different volume target based on the body weight, which may vary from neonates to teens. So we have personalized format for mechanical power by body weight, as you see, or mechanical power but by compliance. But is there any evidence for mechanical power? Yes. So this review published in 2026, you will see here the mechanical power was associated with higher morbidity and mortality. In this paper, also published in 2024, you will find that the personalized mechanical power by body weight showing that the high mechanical power associated with more days in ventilation, more ICU stay, and higher mortality. So, and their cutoff value for the mechanical power personalized by body weight was 0.45 joule per minute per kg. It's important also to understand that the mechanical power is not the only factor. As you can see in this diagram, two different lungs, two different aeration patterns, with one with more consolidation. So if you have the same mechanical power and the energy transferred to both lungs, the lung with more consolidation will be more prone to VILI as the stress and strain will increase. So we need to recruit the lungs by optimizing the beep, which we will talk about later, and also by use other methods, maybe prone position. So let's talk about prone position. As you see in this literature, prone position can help to improve pulmonary aeration, reduce PICU mismatch, and increase homogeneous distribution of transpulmonary pressure, which will help to homogeneous distribution of stress and strain, and eventually will reduce the mechanical power. But will every patient benefit from the prone position? Let's see. So in this nice review, you'll find that not every patient gets the same benefit from prone position. So what was the criteria for those who benefit from prone position? So you have low PF ratio, means severe PRTS, early prone within 36 hours, prone more than 16 hours per day, or average 17 hours per day. And if you remember, this same criteria for our case today. But apart from this criteria, is any other limitation? I would say yes. So a prone position comes with contraindication and complication. So before considering to prone any patient, you need to look for contraindication and observe for complications. Now let's move from VILI to PCILI. So PCILI is a patient self-inflicted lung injury happens when the patient has like severe ARDS, hypoxemia, hypercapnia, lung inflammation, all will increase the respiratory drive, which will increase the respiratory effort and work of breathing, and it will cause more harm to the patient as it will increase the stress and the strain on the lung, will affect the RV preload and afterload, and will reduce the cardiac output as we saw in the previous presentation. This is a vicious circle and we need to intervene to stop it. The intervention can be beep optimization according to the patient need, prone position if there is no contraindication, plus sedation, plus or minus neuromuscular blocker if needed. Now, let's summarize the lung protective strategies. We have strategies related to the ventilator, like tidal volume targets, limits on the plateau pressure and driving pressure, PEEP optimization, lower mechanical power. Things need to monitor like saturation according to the severity of the ARDS, mixed venous SAT, permissive hypercapnia, intrinsic PEEP, and ventilator curves. Extra things may consider like prone position or neuromuscular blocker if needed. Now let's move to PEEP optimization. So let's start with PEEP FiO2 table. So if you have a patient with PRDS and oxygen requirement around 60%, so according to the table, you need to start at 10. So will you start PEEP of 10 or higher or lower? So if your answer, you will start lower than 10. Let's see how this affects our patient. So in this paper that was published in 2018, you will find that the lowest mortality was associated with those who were started on PEEP 1 to 4 higher than the PEEP FiO2 table. So don't be afraid to start higher PEEP and keep reassessing your patient closely to optimize the PEEP. But is the PEEP only thing affecting the mortality? You can see in this paper 3 scenarios. In scenario A, high fixed PEEP, rising driving pressure, rising plateau pressure, and it was associated with high mortality. In scenario B, PEEP increasing, driving pressure remain fixed, and the plateau pressure is rising, and the mortality not as high as A. In last scenario, PEEP kept increasing, driving pressure getting lower, limited plateau pressure, and that was associated with reducing mortality, and that's what we need for our patient. So if you notice in C, it's the concept of lung protective strategies. PEEP titration, limited plateau pressure, but you notice the driving pressure is getting lower. Why? It's because the compliance is improved with optimizing the PEEP. Higher PEEP help it only when it recruited the lung and improved the compliance to get lower driving pressure. And this will take us to the next way of optimizing the PEEP, which is compliance and driving pressure. So compliance is calculated by tidal volume divided by driving pressure. And if you see in this diagram, if you have a collapsed alveoli, you need high driving pressure to open the alveoli and reach tidal volume like 6 ml per kg. And if you have over-distended alveoli, the same, you will need high driving pressure to reach 6 ml per kg. But if you have a nice alveoli recruited and resting at functional residual capacity, you will need low driving pressure to maintain the same tidal volume. So how we use this method to optimize the beep? So we increase the beep gradually and observe tidal volume and the driving pressure. And we will go, once you see the driving pressure going up, you need to go step back, as you see in this nice diagram. The next method of optimizing the beep is lung ultrasound, and it's mainly focused on observing the changes in lung aeration when you optimize the beep. There are many scores used. For example, this is scores explained by Bohemad in 2011, and it correlates well with traditional methods of beep optimization. And you can see in the pictures how lung ultrasound detects the aeration changes with beep adjustment. In this paper also, the ultrasound was used to track the lung aeration, and that helped to find out the opening pressure, the closing pressure, and eventually reaching the optimal beep. So the lung ultrasound is very promising in beep optimization. Let's move to the next way of beep optimization, stress index. Stress index can be seen in the pressure time curve, but it is limited to those on volume control ventilation only. As you see in the volume control ventilation, you will have a period of constant flow, and you need to monitor the pressure curve. So if you have a stress index less than 1, you can see the pressure curve is convex, and means like it is recruitable lung, and you need to increase the beep. If you can see nice flat pressure rise, it is optimal beep to keep the beep same. If you have concave pressure rise, so this means the over-distended lung, and you need to recruit the beep. Okay, so let's move to the next way of beep optimization. One of the most recent and advanced way of beep optimization is electrical impedance tomography, or EIT. So EIT is a machine that sends very small and safe electrical current through electrodes placed around the chest, as you can see in this picture. This measures the resulting voltage and analyzed by algorithm and gives you a real picture of the lung as total and regional. EIT has a lot of benefits, as you can see here. For example, a real picture of the lung showed area of collapse and the area of overdistension. Also in the literature, EIT was associated with low mechanical power. However, it still has some limitation. For example, there is no standard protocol, and it can be affected by like a generalized edema. However, I can see that it will play a great role in the future. Moving to other ways of beep optimization, just to be aware of, there is esophageal pressure guided beep, and this can be done by calculating transpulmonary pressure. And there is also pressure volume loop, where the main idea is to find the lower inflection point. Coming to the end, this is a nice diagram, and this is your take-home message, as it is summarized most of what we discussed today about mechanical power, lung protective strategies, and beep optimization. At the end, thank you for attending this webinar, and I hope it was a useful time for you. These some QR codes I kept for you for further reading if you are interested to know more about mechanical power, beep optimization, electrical impedance tomography, or ultrasound guided lung recruitment. Thank you.
Thank you so much, Dr. Mustafa, for this very nice, thoughtful, informative case-based discussion. Now we are going to move to our last speaker, Dr. Ali from UT Southwestern, and he's going to give us another interesting case-based discussion in the lung protective strategies in the PICU.
Hello, everyone, and thank you for having me with you today. I want you to think of this lecture more or less as a continuation of the cardiopulmonary interactions that Dr. Merva explained and what Dr. Beheri was explaining in his lecture about case-based discussions. So this is more or less talking about safe lung ventilation, but safe lung ventilation takes hours and hours to explain. So here's basic concepts based on the physiology that you need to apply to every single patient that you have to guide you through safe lung ventilation strategies. And this is just basic concepts to build on moving forward. So I want to initially say I don't have any conflicts of interest to disclose. At the beginning of this lecture, I want you to think as simple as this. think of a lung ventilator unit as a balloon connected to a tubing. Those tubings are the ventilator tubings, the ET tube, the airways, the balloon. Think of it as the alveoli itself. Now, the forces that are being applied on that balloon itself is either coming through the tubing, which are from the mechanical ventilation, or it's coming from the patient's spontaneous effort if they're in assisted ventilation mode. So that is an important concept to understand when we're talking about gas. The whole idea that you're ventilating a patient or oxygenating a patient is to have motion of a gas of some sort through these circuits. And to understand this movement of gas, you have to understand that any gas to move needs a force to be applied on it that will help displace that gas, and to have understand what is the rate of displacement or rate of change that occurs in this. And everything occurs in a balance. So it's a balance of forces. The total forces being applied to try to move that gas really depends on what forces that are opposing it. Think of it normally as in physics. So there's resistance and elastic components of the lung, whether it's the lung, the airway, the chest wall, the ventilator tubings themselves. These forces have to overcome these resistive forces or elastic forces to allow flow in and out of the lung itself. So I want you to think in these terms. The force that is applied for the gas is pressure, and pressure is force over an area. And the rate of displacement is the volume, your tidal volume, so that area multiplied by your displacements. And think of the change, the time that needed for that rate of change to occur as the flow, which is this delta volume over the delta of time. And this is the key components of any positive pressure ventilations, if you think of it. Pressure, volume, and flow. And that comes in the concept as any change in pressure is equal to a change of volume over the compliance, in addition to the flow over the multiplied by the resistive forces, plus a constant. And that is the equation of motion of the respiratory system. And that's the basics of any physiology that you'll need to understand in mechanical ventilation, and this is where the core concept that you need to embrace, understanding anything that comes to follow in anything that relates to mechanical ventilation, in my opinion. So now we have to understand what are the applied pressure to the respiratory system. So you have to remember that the forces that need to inflate the lung need to be determined by what? The patient effort and the mechanical ventilation itself. So I want you to think of it this way. The ventilator has pressure applied in the airway, but there's a muscle pressure being also applied in that airway and respiratory system. So now, if a patient is spontaneously breathing, both pressures are applied on the lung. To an extent, you cannot directly measure the muscle pressure, but you can indirectly measure it through different ways. And there's new literature coming up about trying to account for that muscle pressure as well. So I want you to understand if a patient is paralyzed or a patient has SMA and not spontaneously breathing, that muscle pressure comes to zero. But if the patient is spontaneously breathing, then there is element of that muscle pressure that you need to account for when ventilating that patient. To think of it in this way, so PRS is the total pressure applied on the respiratory system. So that's the airway pressure plus the muscular pressure. And you can make terms that change in pressure that we talked about in the gas of motion equation is the change of volume over compliance plus the flow times the resistance. So we know that the pressure and the flow can be measured through transducers on a ventilator, but the volume itself can be determined in different ways, but on a ventilator is mathematically derived, and that's an important concept. So you indirectly measure it through an equation based on the pressure and the flows that you're giving to the patient. So to go back to physics, we know that any action has an opposing reaction. So I want you to think this in elastic and resistive elements of the lung in itself. So now, taking away that pressure, thinking of the volume over compliance, the applied pressure on the airway, it's nothing more than the elastic and the resistive forces of that. And that also has something called entrance. Entrance pressure is negligible. We don't really account for it most of the time. So when we are really thinking of it, we want to take this concept and think of elastin multiplied by volume and resistance multiplied by flow. So I want you to have these concepts next to each other and very close, because this is how we're going to account for stress and strain. How do you account for safe mechanical ventilation moving forward? So now that we can say that the airway pressure, again, is equivalent to those. And this is how it interplays with elasticity and resistance of the airway and the lung components. It's very important to understand that the quotient of volume displacement over compliance represents the pressure necessary to overcome the elastic forces above the resting lung volume. And the resting lung volume is the functional residual capacity of the lung. And this is important for an interplay that we're going to explain later on. But what is optimal PEEP, what is ideal PEEP, and where that sits on the functional residual capacity curve. So, basics that we're building on. There is positive end expiratory pressure, there is bi-level, there's inspiratory pressure that goes into it. There's a difference between pressure, which is the PIP and the PEEP. And we have to account in a units of time of how this pressure occurs, because it interplays. Now, understanding that the peak inspiratory pressure is not equal to plateau pressure. Peak inspiratory pressure is the pressure that the maximum pressure that the ventilator has generated to give that patient the volume that you requested, or that pressure that needed to overcome whatever lung compliance we're sitting in. And this is pressure controlled, and that's the PIP that you have set. The plateau pressure is the real pressure that the lungs are actually seeing, the alveoli units are actually seeing an alveoli spectrum. So there is a difference between them, and we shouldn't always account that and think that they are equal per se. So taking that concept in mind, we have to understand there's something called the driving pressure, and the driving pressure is the difference between the plateau pressure and that PEEP. And why did we talk about that driving pressure? Because we want to think of it in a concept of what is the pressure that the lung is actually seeing to reach, and what is the difference between what is the pressure that keeps the lung open at all time. And that is where the driving pressure sits. When we understand at the end of those delta P, that is the tidal volume. And that is the relation between the pressure volume curves on the lung. So what does that tell me? That the peak inspiratory pressure and the plateau pressure, the difference between them accounts of the airway resistance of the lung. So the ventilator can generate high peak pressures, but the alveolar units are not seeing that peak pressures, are actually seeing a lower plateau pressure. And that accounts for the resistive components of the airway. Now, it's important to realize that the driving pressure, which is the difference between the plateau pressure and PEEP, is a reflective of the intrapulmonary compliance. And that where it comes in resistant and elastic concepts again. So let's build on it one more step. So when you're actually paralyzing a patient, putting them in volume control mode and measuring a true end inspiratory hold. So you're doing an inspiratory hold to see that patient's plateau pressure. So you paralyze them, you have them in a true volume control to make sure the flow is constant and intermittent. You can do it from PRBC, you can do it from volume control, preferably in volume control. And you press on that inspiratory hold and you see a difference between your peak pressure and your plateau pressure. You realize that difference is less than 5. So you know that that peak pressure is to an extent what the lung is actually seeing. It's not overcoming a lot of resistance in the airway to reach the lung. So that tells me that there is an actual concern of parenchymal lung disease there, or that the patient has hyperinflation and needs a lot of pressure to overcome the hyperinflation. Think also, if there's a high gap between the peak pressure and plateau pressure, so more around 5, think of more of obstructive pathology. There's something that is obstructing along the way. There is resistance along the airway. So think more bronchospasm, asthma. Think more mucus plugging. Think of endotracheal tube occlusion. So you have to understand, account for that difference between plateau pressure and peak pressures, account for that driving pressure to guide what the actual alveoli are seeing. And when you think of this, you have to think of it in the total cycle of time that the patient is actually seeing this. At times, people don't account for eye time as much or respiratory rate when thinking of that patient's peak pressures or of that patient's plateau pressure and driving pressure. It all factors in together. You giving the patient more time to breathe, less respiratory rate affects your peak pressure because it all goes in the unit of time. If you account for what we said, forces being applied in the gas to make any displacement, what is the rate of that displacement goes into. So as we said, this is how we connect it to this. So that makes an understanding of what the difference between peak pressures and plateau pressures. We'll take it a bit one more step further, and let's explain the difference between plateau pressures in static and dynamic compliance. So a dynamic compliance, which I'll explain later on, is accounted between a PIP and a PEEP, while a static compliance is when your flow is at zero, right? Your flow is zero, is static compliance, is the difference between your plateau pressure and your PEEP pressure. So how does that factor in the full equation? But before I talk about the equation, you have to understand plateau pressure does not always mean it's less than the peak inspiratory pressure. Actually, it can be the same, or it can be even more. So if you account for the patient's muscle pressure and the patient is having dysynchrony, or there's increased muscular pressure applied by the patient itself, for example, in the P-Silly, your plateau pressure is going to be higher than your PEEP or closer to your PIP. So you have to account for the difference between your lower plateau, your same plateau, or your higher plateau than your PIP pressure. So that builds back to the concept of what is dynamic compliance. And when we talked about dynamic compliance over here, we're talking about both of them are change in volume over change in pressure. But what pressure changes are we talking about? Regardless, it is the tidal volume. But dynamic compliance is more of the PIP minus the PEEP, while static compliance, when the flow is zero, is the plateau minus the PEEP. And these are important factors to drive safe ventilation. So when we think of this and think of the volume pressure curve, we have to understand where does true FRC sits on that curve. We have to understand this. The delta P that we talked about earlier on the volume pressure curve, if the delta P is 5 across all of these, does not mean you're getting the same volumes. If you're at the end of the atelectic trauma, so atelectatic lungs, rather than overdistension, your delta P is not going to give you the same volume that you're thinking and will cause more volume trauma to achieve it. So if you have a recruited lung, like in B, and you have an ideal functional residual capacity, then your delta of 5 might actually give you a higher volume than it will give you in the atelectasis, which is A, or the overdistension, which is C. So you have to recruit your lung to have an ideal functional residual capacity to actually get your gain of delta P, to actually get the volume that you need. And this essential concept to understand when you're trying to recruit your lung to have it there. And this is the exact concept where you have to understand where the zone of overdistension, the zone of under recruitments, and where your ideal PEEP have to sit to actually recruit your lungs. So that coming into here, this is also highlights what the ideal functional residual capacity sits. We understand that functional residual capacity has much of interplay with the pulmonary vascular resistance. And if you're atelectatic or overdistended, you're really affecting your PVR. And so when you have an ideal recruitment of your lung, you have ideal functional residual capacity and find the right PEEP that we talked about earlier, then you will able to get your gain to the butt for your recruitments. This has to factor in the concept about your intrinsic PEEP. So understand this concept of if you're having a patient, you're giving PEEP from outside, that's called extrinsic PEEP. That's the PEEP you set on the ventilator. But at times the patient starts air trapping or not truly emptying all of the lungs, then you have a problem with intrinsic PEEP. Retention. Intrinsic PEEP is the PEEP that the patient has. At times it's labeled as the O2 PEEP. This is the PEEP the patient is generating or the lungs is seeing. And total PEEP is basically the addition of extrinsic PEEP and intrinsic PEEP. And for you to measure this, you have to do an expiratory hold to see what the patient total PEEP is. Subtract that from your set PEEP, which is your extrinsic PEEP, to figure out if the patient is O2-peeping. This is important as well to realize that on your servo-ventilators, when you see this flow, which is not getting it till the end, or your volume loop curve was peaking here. It's also important to look at your vent at times it has end expiratory flow and tells you it should reach a 0. And if it's not reaching a 0, it's more like 2 to 5. Like at times you see at 1, 2 to 5, then think of the patient is holding more or air trapping. And this is an important concept to understand when you're thinking of the Pendeloff effect. Because your intrinsic PEEP, when it's present, there is more effort that is needed by the patient and the ventilator to generate enough flow to move the gas into the lung. And this is important because this concept understands that the flow is still occurring within the lung as the alveoli are trying to achieve their baseline state. And this is important because each alveoli of the lung, especially ARDS, which is a heterogeneous disease, has a different time constants. So overfilling of the alveoli might start emptying in the underfilled lung alveoli for both of them to achieve their restorative resting volume. So Pendeloff effect is this movement of continuous flow still in the lung as you're thinking of expiring, like you're done with the inspiratory phase going to the expiratory phase, but the alveoli are still not emptying completely. And then the next cycle starts. So this is an important concept to understand that the time constant varies a lot in the heterogeneity of the disease. And it's basically, to define time constant, it is about 63% of the time that is required to inflate the lung to the final volume that you have, or deflate it from the current state. So accounting for a time constant is essential. And this factors in, again, I time, respiratory rate, and the cycle that you have in your ventilator. Explaining all of these concepts comes to the last few slides. 1, we know that there is pressure applied on the airway. We know there is transpulmonary pressure, and there is pleural pressure. And then the transpulmonary pressure is the difference between the airway pressure and the pleural pressure. And this is what we need to maintain. So the concept ends being stress and strain. Stress on the lung is any force that is applied on the surface area. So I want you to think of it as transpulmonary pressure. Lung strain is the change in the lung size from its original volume. So I want you to think of it as the tidal volume that changes over the functional residual capacity. That's the original volume. So with the high strain, then the tidal volumes are relatively high to the lung size at the end of expiration. So the patient is in high strain, and hence strain is a volume trauma. So think of it as why low tidal volume strategies are most important in patients with ARDS, because these patients have largest reduction in their functional residual capacity. And if you're giving them high tidal volume, you're giving a high strain on that lung, and that causes more volume trauma and lung injury. Stress is high when the end inspiratory transpulmonary pressure is elevated. So think of plateau pressure and driving pressure. So high stress on the lung is correlated to high mortality rates. Hence in ARDS, we're thinking more of driving pressures and plateau pressures, which we're going to review the numbers later on. But think again, you want a driving pressure less than 15, you want a plateau pressure less than 28 or 32. And this accounts in the stress and strain of the lung. This is very essential because if you think of PICU, and PICU is the patient self-induced lung injury, there's large sway of transpulmonary pressures. So there's high stress, but also high strains in the lung with low alveolar pressure. And this is an important phenomenon because PICU is predominantly due to worsening of the Pendeloff phenomena, which causes strenuous efforts and local volume trauma in multiple sites of the lung. And this is a concept that is built from stress and strain. It's essential as well to understand ventilator-induced diaphragmatic dysfunction, because eventually at the end of the day, that factors in that if you give a patient high stress and strain on their lung, you have the patient over-distended, sedated, a neuromuscular blockade, you're not using your diaphragm as much and causing injury. So that will cause you having worse and worse rehabilitation of that patient when you're trying to get them to extubation. So you have to factor in what's happening to diaphragm, not just your lungs, when you're trying to rehab the patient for extubation. And the last few slides, you have to understand that there's a respiratory rate effect. So as explained in the previous lecture, what is ergotrauma? We talked a lot more about mechanical power. Think of respiratory rate as not as a benign thing. Think of a boxer who can punch with one strong punch versus small rapid punches repeatedly. What causes more injury over a longer time? A faster rate. Think of respiratory rate as a multiplier of energy delivered to the lung per unit of time. So respiratory rate has an injurious effect to the lung as well, not just think of volume or think of pressure. Think of your respiratory rate. High respiratory rate increases your mechanical power, increases your energy load. This causes more cyclic stretch injury, causes dynamic hyperinflation, causing O2 PEEP. All of this is essential to understand when factoring in the rate. Just because we're going over time, quickly summarizing of this case is you have a 2-year-old admitted with ARDS. You have an SIMV. You're trying to factor in that recruitment. The patient is FA2 is about 70%. Their PEEP is about 8. You want to look at what we discussed earlier in the previous lectures. Where's the patient sits on the low PEEP high FA2 curve? And this patient sits basically in the 70 FI2. So think of a PEEP 10, 12, or 14 being ideal for this patient. You start doing recruitment maneuvers for this patient, and you have to account for everything. So you start a PEEP of 8, where the PEEP was sitting at. Look at where your plateau pressure, look at where your driving pressure, and measuring every single step where your static pressure is. I'm going to leave the dynamic compliance for you guys to do the math and fill. You have to account for where the blood pressure of the patient is sitting and where the pulse pressure and pulse pressure variations is accounted for. And I want you to look at it here in these factors. As you start recruiting the lung more, you see you have an ideal PEEP of 12, PEEP to best compliance. When your driving pressures drop to 15, you have good volume recruitment, which you can actually back off and lower your driving pressure because 8 is a bit too much. You find your static compliance has improved, your saturation has improved, your blood pressure is ideal, and your pulse pressure and your pulse pressure variation is actually good. Now, pushing that further up in the PEEP curve, you'll find worsening static compliance, worsening volume recruitment, higher driving pressures, and you start seeing hemodynamic compromise, which is accounted for in your cardiopulmonary interactions. So as you go, and with each step of PEEP recruitment by figures of 2, even though ARDSNet said 5, but we're doing it in figures of 2, you'll see you're accounting for measuring driving pressure and static compliance at every single step of the way, looking at your blood pressure, your pulse pressure and pulse pressure variation every single step, and seeing where your lung compliance and your hemodynamic compliance are occurring in the things of cardiopulmonary interactions. To summarize, all of this is essential. We recognize that the recommendations from PALICI and the PALIC group, this is where the recommendations are coming from. This is why we're avoiding higher tidal volumes, why respiratory rate is essential to recognize. This is why the plateau pressure and driving pressures are essential, where we can individualize the PEEP and not just go up in the low PEEP FA2 or high PEEP FA2 table, but make it as a customized, individualized PEEP plan and allowing permissive hypercapnia while maintaining pH above 7.25, which is also by itself is an essential understanding of why we're doing it, which is outside of the scope of this lecture for now. Thank you, and I hope you benefit from it, and I'm open for any questions afterwards.
Hi, thank you all. My name is Michael Canary, and I'm going to moderate here and pose some questions for our speakers. First, I want to thank Drs. Mervet, Mustafa, and Ali for such a succinct yet comprehensive overview of so many of the core concepts related to vent management, not just in congenital heart disease, but also lung protective strategies and ARDS. It's not easy to encapsulate these ideas and make them so digestible. So thank you very much. I'd say that it's very interesting to see how our strategies for managing ventilators have evolved in the face of new evidence, and it's really interesting to watch us and see how we currently account for factors such as, mechanical power and lung stress and strain, and ways we can identify that and also mitigate the harm to our patients. And it's really exciting to see how these sort of core physiologic concepts, how we can link them with practical approaches to our patients. But I think at the end of the day, what this also emphasizes just how dynamic a process it is, and how there's no way around vigilance, constant monitoring, and adjustment to not just the patient, but how the patient is responding to everything we're doing. Now, I see a couple comments in there, and I'd like to invite you to put more questions in the box if you want. But I suppose I would ask Dr. Merveille or to comment on this. Dr. Mazen Ghanem commented that regarding your talk, that these points highlight that in pediatric cardiac patients, the ventilator is not just a supportive device, a lung supportive device, but a powerful modulator of cardiovascular physiology that is highly personalized to the physiology and the condition of the patient. Any comments on that, Dr. Merveille?
Dr. Mervat, the question is for you.
Yes, thank you, Professor Canary, and thank you for Dr. Mazen. It's actually the conclusion of my lecture. We can modify the ventilatory settings according to the cardiac condition of the patients. Sometimes we need to ventilate our patients if their issue is to lower the vascular resistance, but with caution. We can as well use the ventilatory support for low cardiac output and the cardiogenic shock to unload the left ventricle, as we have said in our lecture. So actually, ventilation is really some sort of a hemodynamic support rather than it is only for oxygenation and for CO2 wash.
Thank you. And this no doubt informs your decisions based on early versus delayed extubation following surgery.
Okay. Regarding the cardiac surgery, you mean, right? Surgeons always push for cardiac, for early extubation, fast track, and sometimes we struggle with them. But we all agreed for early extubation if it's mainly a right-sided pathology or RV pathology like post-fallow repair or frontal physiology or single ventricle physiology, because post-pressure ventilation is an adding afterload for the RV. But sometimes we need to continue ventilation to support the hemodynamics, and we keep watching the preloading, especially in these patients, and we can decrease pulmonary vascular resistance by means of increasing the oxygenation or accepting the hypercapnia PET, and ventilating our patients around the functional residual capacity with avoidance of atelectasis and hyperinflation as well. And they are mostly right in this situation, and we can early extubate our patients unless our cardiac function is impaired. But on the other side, in other pathophysiologies, when we have signs of low cardiac output, and sometimes we are pushed by the surgeons for early extubation, and sometimes we went into a struggle with the surgeons for such situation. And if we go after their strategy, we actually re-intubate the patients afterwards. if they have subtle LV dysfunction or poor LV dysfunction. And we cannot recommend the early extubation or fast track extubation unless we are sure the patient is hemodynamically stable, not fragile, well perfused, even after surgical compression, surgical pressure, I mean.
Thank you very much. An excellent response. Dr. Mustafa, you gave a great overview. I mean, you really simplified some very difficult concepts. And I have a question for you from Dr. Tujan Ragab, and I'd like to tag on a question as well. So he wants to know the benefits of permissive hypercapnia, and I'd like to tag on to that. So for years, we engaged in permissive hypercapnia principally by having low tidal volumes and a higher respiratory rate. Now we learn that the respiratory rate is transferring mechanical power to the lungs and harming our patients.
Yes.
So what are the benefits of permissive hypercapnia, and how do we harmonize these approaches?
Yeah, so permissive hypercapnia is not as a target for us. It enables us to reach the target for limiting the pressure and limiting the driving pressure. So as we see in the literature I have shared with you, first in Amato 2015, you can find that driving pressure was also caused, like high driving pressure was associated with high mortality. So it is enabling us to continue the lung protective strategies. So limit the driving pressure, limit the tidal volume, and as we said, the mechanical power, it depends in combining with the driving pressure and tidal volume, the respiratory rate. So if you allow some permissive hypercapnia, it would allow you to reduce the rate, reduce the mechanical power and the energy, and will reduce the mortality for the patient. So it is not the target for permissive hypercapnia, but it is allow us to do the lung protective strategies.
That's a great way of expressing it. So hypercapnia is not beneficial, but it prevents you from doing things that will harm the patient.
Yes, exactly. Yeah.
Great. Thank you very much. So there's a question there that I would open up to both of you. And I'm sorry, data in favor or against incremental or decremental PEEP approaches to set up PEEP in, I'm sorry, I don't fully understand the question. So let me pose one of my own to Dr. Mustafa. Your use of POCUS, of bedside ultrasound, is that standard practice for you now when managing in titrating PEEP? Because it's
So I work
yeah.
in pediatric cardiac ICU, so we don't see a lot of pediatric ARDS, but we rely a lot on POCUS. So when we had a pediatric ARDS case, we use the POCUS to help us in determining the beep, because as Dr. Mervet said in her lectures, that the beep, it could be harmful in certain cases, affecting the hemodynamics, either for positive or negative, but I am talking about the negative part of hemodynamics now. So the POCUS will help us to reach the optimal beep, and we can wean it to see the opening pressure when the alveoli open and recruited. And when we start to decrease the beep again, and we start to see the consolidation and increasing of the B line to be coalescent B line, so it means that alveoli start to close. So we start to increase again, like 2 above this beep, the one we see is closing pressure, to reach the optimal beep for us.
Whoever knew that looking at B lines would have such an influence on our clinical practice.
Yes, yeah.
But it's essential now. Dr. Mervat, is using a POCUS at the bedside something that you do frequently in your practice, and what specific ways do you manipulate it?
We can use it only for lung issue to differentiate between overload, collapses, pneumonia, consolidation, and for rapid assessment of a pneumothorax. But yet we are not using it to optimize the beep.
Okay, great. I'm looking. Okay, there's one question here. And I'll pose this to both of you, and I'm not sure if Dr. Al-Husseini, if we have time. So let me just do this one question here, and that is prone position a step that I do after a certain PEEP, or what is the timing to prone a patient with ARDS?
Yeah, so I shared one table. The table has a review for certain paper, and you can find in the most of the paper, the prone position didn't reduce the ventilation days, except in one paper, and the criteria was severe PARDS, so PF ratio less than 100, and prone position was started early, less than 36 hours of the insult, okay? And the routine itself, it was an average of 17 hours. So I would say at least 16 hours prone and 8 hours supine. So this was the criteria we look for. And this also some contraindication we have to avoid if we are thinking of prone a patient.
Great. Anything to add to that, Dr. Mervat? Yeah, I would. Yeah, go ahead.
We have a good experience in proning the patients while they are having an ARDS. After excluding patients with pulmonary hypertension or hemodynamically unstable or with any mechanical difficulty to prone them, we shift our patients to a prone position after trying a high PEEP with no adequate recruitment. We use it over than 16 hours a day. We didn't have a study done to compare patients with proning or a patient without proning, but we found unacceptable results in moderate ARDS and severe ARDS regarding the overall outcome and the recruitment by the, as we see, by the expansion of the X-ray, and we can lower the pressures a bit faster while we are proning our patients. This is our observation.
Right. So in sum, it's not a certain PEEP that you would go beyond that would compel you to prone a patient, but rather their overall status, and whether you use OIs or OSIs or whatever, and whether or not there's a lung that's recruitable. Thank you. Now, Dr. Fatima has a question that may go beyond the scope of our time here, but interested in knowing the benefits, negative fluid balance, and then brush through Fontan physiology. I think that may be a lecture unto itself. A very interesting question, but I think that maybe, and I'm not sure if we want to link the negative fluid balance with Fontan physiology, but maybe just a word on your views on negative fluid balance.
Okay.
I can say to start it off that I'm in favor of a negative fluid balance, except in a Fontan.
Okay, sure. It's a preload dependent physiology, and you need to have a loading for this patient because we don't have a subpulmonic ventricle to support the pulmonary circulation. But it's in general, we support the negative fluid balance in our patients who are mechanically ventilated, especially before extubation, especially in those with LV poor function or borderline LV function. So I just want to emphasize having a cumulative negative fluid balance. It's not only for the day of extubation, which should be negative. We need to have a cumulative negative balance for our patients using diuresis before extubation to avoid the flash pulmonary edema, which may complicate extubation due to a marked increase in the venous return after changing the intrathoracic pressure from positive to negative with extubation. And this will unmask a poor LV function and may manifest pulmonary edema. So I didn't mean being a negative balance with Fontan physiology, but in other pathology, especially if I have an LV dysfunction.
Thank you very much. Dr. El-Husseini, if you don't mind, I'm going to give Dr. Ragab the last word. She has a comment to make.
Hi, Michael. I just wanted to, my name is Rehab Saidi. I just wanted to add a comment for both Mustafa and for Ali, Dr. Mustafa and Dr. Ali. Regarding the rate of restrictive lung diseases like ERDS, actually there is a fact that the time constant in ERDS is very short. And this is why we are not concerned from increasing the rate in terms of the air trapping or O2P, because this won't happen. There is if you increase the rate a bit to correct the respiratory acidosis in case of ERDS, because of the very short time constant in ERDS, the chances to have an O2P or air trapping are very low. This is one point. The second point regarding the patient self-inflicted lung injury, which was mentioned by Mustafa earlier. Mustafa, I heard him debating about muscle relaxant, but actually I didn't get his conclusion to start a muscle relaxant for ERDS in the acute stage in order to avoid the patient self-inflicted or not. And another question for Mustafa about the recommended moods in the ERDS. If you are concerned about patient self-inflicted lung injury, are you going to put the patient on the mandatory moods or intermittent mandatory?
Okay, first regarding the respiratory, I commented only on the respiratory during the mechanical power. So my concern with the respiratory is just the mechanical power and the force and the energy affecting the lung and the lung injury. Regarding the patient self-inflicted injury for the neuromuscular blocker, I said in our case we use the neuromuscular blocker. So I will use the neuromuscular blocker if we have a patient with suspected CLE, increased respiratory efforts. I will use it at the beginning, okay, maybe short term, maybe one day or 48 hours to make sure this is not increasing the stress and strain on the patient and making more harm for the patient than benefit. Regarding the mode, if I'm using the neuromuscular blocker, so I will use controlled mandatory ventilation at the beginning. I'm not sure if I missed any other question or not. I'm sorry.
No, thank you. I totally agree. During the very early stage of the severity of acute respiratory distress syndrome, we do use the blockers for the first 24 hours. I agree with you to avoid the patient self-inflicted lung injury. But the point I like to highlight it is that in ERDS, if we are using lung protective strategies and the tidal volumes are really low and really tight, so you will easily lose your minute ventilation and the patient is going to develop very bad respiratory acidosis beyond the accepted permissive hypercapnia. And this is why we rely on the rate to correct the minute ventilation. And in terms of the very short time constant, we are not concerned about air trapping. I just gathered your lecture side by along with Ali's lecture.
Okay, yeah.
Thank you so much, everyone, for the marvelous contribution. Before I give the closing remark, I just want to give a comment regarding the negative fluid balance in cardiorenal physiology from the renal perspective, because I'm a nephrologist. So I like to comment on this because nephrologists hate the negative fluid balance. But when it comes to the cardiorenal physiology, if you can improve the preload or afterload physiology by any mean, this would impact the renal function positively. If you are talking about permissive hypercarbia, we are also talking about permissive hypercreatinemia. Don't worry about rising creatinine initially or high BUN at the beginning. Studies show that the long-term impact of making a negative fluid balance to improve the cardiac function would eventually improve the renal function, even if at the beginning the effective renal plasma flow will go down. The kidney might suffer at the beginning, but the outcome would be much better compared to those with volume overload that would compromise their cardiac output and eventually their renal perfusion and kidney function as well. With that, I'm very happy to say thank you everyone for almost being patient with us for almost 1.5 hours. Very thoughtful discussion, very informative lecture. Thank you, Mike, for the marvelous moderation as usual. Thank you so much, Mervat and Mustafa and Ali for the very nice presentation. We would have another webinar next month, so please stay tuned. We'll share all the information shortly. By next week, all attendees should get certificate of attendance. And by tomorrow, all of you should get the YouTube link of this recorded webinar. And with that, I wish good rest of your day, afternoon, evening, and night.
Thank you so much. Bye.
Bye.
Thank you all.
Bye.